Right. Good evening, everybody, and welcome to the Parliamentary and Scientific Committee inaugural Zoom seminar. Apologies for having kept you waiting. We had a little technical difficulty, but that's now been resolved. So I'm very grateful for you all coming along. This is the first such meeting that the Parliamentary and Scientific Committee have conducted during these strange and challenging times. It couldn't be on anything else other than COVID-19. But rather than talk about the medical aspect of that, I was rather keen that we explore the statistics and the science underlying the statistics, because of course a lot of the decisions are based on numbers. This is all about numbers and how they impact on the models that are used to predict how the virus may spread, on what is and isn't safe to do, on the decisions around opening certain businesses and what we should adopt in terms of social distancing. And so I'm really grateful to the team for pulling together 4 excellent speakers who are going to take us through this very interesting subject. What I'm going to do is, because we're running slightly late, I'm going to go straight to our first speaker. Each speaker has about 15 minutes. I will try and indicate when there's time to wind up. If each speaker, as I come to you, could just tell us your job title and then go into your presentation, I'd be very grateful. So I'm going to start off, if I may, with Professor Sylvia Richardson, who's going to talk to us about tackling COVID-19 statistics in action. Sylvia, over to you. Thank you very much. 15 minutes.
Thank you very much. Let me try to share my screen. So, is this working?
Yeah.
There.
There.
Full view. Fully. There. So thank you very much for inviting me. I'm Sylvia Richardson. I'm Professor of Biostatistics at the University of Cambridge and Director of the MRC Biostatistics Unit. So the general aim of my talk is to discuss how statistics is contributing to produce evidence on many aspects of COVID-19, evidence which can inform policy decision. And I will illustrate this through the work that the MRC Biostatistics Unit has engaged on COVID since March. So in early February, little was known on COVID infections, except that the virus characteristics which are coming from China already indicated how dangerous this virus could be for the world. There were, and there still are, many unanswered questions ranging from basic science to population burden. But progress has been achieved by melding the scientific questions, appropriate data collection, and suitable analytical tools. The MRC unit quickly convened and set up a COVID-19 working group, which got involved in a spectrum of methodological work, ranging from trying to understand the immune response to COVID-19, designing adaptive trials, evaluating clinical and resource management, estimating severity, and nowcasting and forecasting. These covered a wide range of aspects of the health aspect of COVID-19. We found that a common thread to effective engagement was to build on an established network of collaborators to spend time on a detailed understanding of the data collection and to use principal statistical analysis accounting for the data collection and tailored to the question investigated. So I will now briefly review these areas of work and show some of the challenges that statisticians are facing. It quickly became apparent that COVID-19 has particular characteristics and particular influence on the immune and inflammatory responses to COVID. And as in the diagram below, which illustrates this, you could see that for some patients, the initial viral response phase is followed by an inflammatory response, which sometimes goes in overdrive with very serious health consequences, which can be lethal. We participated in a project to try to study the different phases of the immune responses. The protocol benefits from having both staff screening and patients, and so it can recruit patients from healthy control, or individuals from healthy control and people having very little symptoms to very severe patients, to really capture the whole spectrum. And on all these individuals, an extensive set of biomarkers will be analyzed. Here I'm showing you some simple example of analysis which shows the impact of COVID-19 on different types of immune cells. Here the B cells, the T cells, and the plasmablast. The most severe patients are on the right-hand side, these two violent plots. And you could see clearly a depletion of B cells and T cells with respect to the milder case or the healthy control. You could also see possibly an increase of plasmablast. But what's particularly notable is that there is a lot of heterogeneity of the response. And since the protocol includes an extensive set of immunophenotype biomarkers, we are dropping one at a time analysis and going on to using multidimensional statistical analysis to characterize sets of patients with similar immune responses. In early 2020, there was no approved treatment for COVID-19, and WHO and Nowcasting advised that several potential treatments should be evaluated urgently, but that other treatment will emerge which will need evaluation. And so the community got together to set up a very large randomized clinical trial with multiple arms and flexible design. In our unit, we had already a track record of focusing on methodologic work on adaptive designs. What are these adapting designs? They are efficient designs which permits to evaluate treatment in a way that, for example, several arms can be compared to common controls, and the treatment can be changed or stopped at interim analysis, so much more flexible. But what is important is that the integrity and the validity of the results is maintained through this more flexible protocol. So the recovery trial started in 19th of March, which compared 4 treatments to standard of care. And it got off to a flying start with almost 1,000 patients recruited in the first 15 days. On the 24th of April, another second level randomization was added. And then at the beginning of June, the first interim analysis was recommended by the Data Monitoring Committee, which found that there was no beneficial effect of hydroxychloroquine, and hence recruitment in this arm was stopped immediately. Shortly afterwards, a second analysis this time showed a benefit of dexamethasone, particularly for the ventilated patient. So again, recruitment in this arm was stopped immediately, and this was recommended for standard of care. So basically, evaluation of treatment at pace has been enabled while maintaining the validity of the results, because underpinning methodological research on adaptive design had been developed. It's known that COVID-19 places a huge burden on healthcare resources, and in particular on intensive care units. So knowing how to target care to patients in most need is important. We're involved in a large project on ICU electronic records, which is coordinated by HDR UK and the Alan Turing Institute, deCOVID. But we also started collaborating with clinicians at Addenbrooke's Hospital to start a project on ICU records at Addenbrooke's. The project started early on the 10th of March. Approval and initial data extraction was obtained within a month, but to manage to have the data in safe haven where the modern data science tool can be used took still quite a significant time. And this is necessary because the raw data is absolutely massive. To show you the type of results that we are looking at, for example, is a measure of compliance of the lung in the first 24 hours. Is it going to be predictive of different trajectories for COVID-19 patient? And you could see that, yes, it is. If you follow the fraction of ventilated patient over time on this plot on the right, you could see that on the first group, they are much longer. The patients stay much longer on ventilations. Quantifying severity is important, and to do that, it's useful to characterize the disease course. This can be thought as a multi-stage process. Infected individuals follow a succession of states which correspond to stages of their disease. To characterize this process, we can evaluate the transition probability from a state to another one, and we could also characterize the length of stays. We have focused on the most severe patients, either following the flows of the hospitalized patients. Most information on the disease course in hospital comes from observational data which was collected for other purposes like audit or hospital management. The two main sources of data are the CHESS system, which was set up by PHE, and the COSIN clinical information networks. But as these data sources are not purpose-built, it's important to keep in mind issues related to inconsistency, missing data, censoring, and the selection of the population, because this will have impact on the results and impact on the interpretation. We're interested in evaluating the transition between these 8 states and the length of stay. When the first look at raw data, for example, from the COSIN data set, show many inconsistencies. And in fact, so there is careful data processing of the record which is needed, with losing about 10% of the record to be able to assemble a data set which can be analyzed as a multi-state model. It's also important to know that these two main surveillance systems of hospitalized patients address different population. For both of them, you see there's more male hospitalized patient than female, and this is well known, but the COSIN data set has a much larger fraction of elderly patients. This has impact on the results, for example, on the probability of transition. Here I've shown only the probability of transition between the hospitalized states and the other 3 states. If one, for example, look at the probability of transition into ICU, you could see that about 30% for the CHESS and about 10% for the COSIN data set. So the recruitment of the hospitalized population has clearly an impact on the results. Finally, Nowcasting and Forecasting has been a very important piece of work, which is led by Daniela De Angelis, who will give the next talk, and this started in early March 20, joint collaboration with PHE. And so I will not give any more detail, and I would leave Daniela explaining the impact that this has had on influencing public health policy. I will summarize the role of statistics in this crisis. Our job is to produce evidence from data and quantifying uncertainty. And we do that using principal statistical analysis. And in particular, important to highlight the assumptions and the sensitivity and to try to communicate that to policymakers. Of course, to be able to work, there need to be availability of data and data of good quality. So this is of paramount importance. There's been a huge mobilization of the scientific community. And as I've tried to illustrate, statisticians are involved in the whole spectrum of projects. It's been very useful to be able to exploit routine data collections. And the UK has a very high international track record in this area through HDR UK and all the linked database. But one must remember that observational data has its limitation and needs careful analysis and interpretation. Hence, it's also very important to be able to set up fast, well-designed and well-conducted study to answer possible future threats. So great strides have been made, but there's some lesson to be learned in preparing for the future, including the ability to set up comprehensive, well-designed and aligned data stream for surveillance, which capture multifacets of the infection. Also to develop methods which will be able to triangulate fast and in an interpretable way this evidence in the context of surveillance, and to carry on constant evaluation of operational systems and policy. So I will end up by thanking the COVID-19 working group in our units for their stellar work and dedicated work, and acknowledging all our collaborators. Thank you.
Sylvia, that was absolutely perfect. 15 minutes. Thank you very much indeed. And just before I go to Daniela, just a quick question, if I may, which is the data and the analysis that you've done and the patterns that you've spotted from collecting that data. Would that be possible to be repurposed to allow people to make an informed decision about their own personal risk as we have to get used to living alongside this virus?
Yes, definitely some of it. For example, the study of the immune system, the ultimate aim is to be able to develop biomarkers so that we could actually predict the more severe patient and try to target treatment to them. So not necessarily, the general public, but the whole purpose is actually to capture and then to have a better way of identifying, precision medicine to identify the better treatment for people. Similarly, in terms of hospital management and the resources and the ICU studies, again, the idea is that we could actually capture a predictive pattern at the beginning when somebody starts in ICU. So we'll be able to manage and treat that person better. Also, some of the large data set, like the COSIN data set, have captured many risk factors which have been analyzed. And of course, these can be used to do prediction for risk for the population.
Thank you very much indeed. Very, very interesting. Right, we're going to move swiftly on to Dr. Daniela De Angelis, who is going to talk to us about real-time nowcasting and forecasting of COVID-19 in the UK and the first wave. Daniela, over to you. Daniela, I think you're still muted. Hello, Daniela?
Okay.
That's better, yes.
Yeah, can you see my screen?
No, for me it's blank.
Ah.
Black, I mean.
Okay, I'll try again. It was working before?
was working a moment ago. We
Yeah.
had pictures of your slides.
I don't-
The bars across the top. Oh,
I can try again. Okay, let me try again.
There we go.
there we go.
Can you see?
Yes.
Yep.
Okay, this, yeah, let me see if I can go on full screen. I'm a bit nervous now to touch anything, but I'll try.
No, it doesn't like that.
It doesn't like.
It doesn't like that. Okay, I might have to use it without. Sorry, I'll try.
We can see the slides. It's just there's a bit of clutter around them, but
Yeah.
Talk to them.
Sorry for this. Anyway, in the meantime, I can introduce myself. I'm a professor of statistical science for health at the University of Cambridge, and I'm a program leader and deputy director in the MRC Biostatistics unit, the same unit as Sylvia. I'll try again now, okay? There we go. I will do the full screen first, and then I'll do the sharing and see whether this is better.
Okay.
Anyway, while this is not working, I can start telling you about the work that we've been doing. Can you see anything?
Yeah, we can see. Yeah, we can see the slides. I think it's fine like this. It doesn't need to be in full screen.
It is in full screen for me. No?
We'll go to slide number 2 and let's see what we get.
Yeah?
It's not moving for us, Danny.
Okay, I don't know. Okay, let me have a look again. I apologize for this. I don't know why it's doing this. It's saying that the screen is pulled sharing. I don't know why. Okay, I'll try again. Maybe not in full screen. And okay, let me see.
That's it. We've got that.
That looks better.
Okay, so hopefully you can see that. Sorry for this, and thank you for your questions. Okay, so I've introduced myself, and I'm going to tell you in the 15 minutes left something about the work that we've been doing in the last 4 months about estimating and predicting the COVID-19 epidemic or pandemic, I should say, in the UK. I have put a very controversial title, "The First Wave ? Okay, let me just start from where we are now. At the 28th of June 2020, over 300,000 lab confirmed cases. We had over 300,000 lab confirmed cases, over 43,000 deaths among those lab confirmed cases. We have learned the pandemic in this country is made up of 3 sub-pandemic, 1 in the community, 1 in hospital, and 1 in care homes. The government has introduced a lockdown on the 23rd of March, and from May the 13th, the lockdown has been gradually lifted. Now, this is where we are, and we are here because various decisions were made by politicians, and you know at this point that some of these decisions were actually informed by scientific evidence. Now, how did the interaction, how was the interaction between science and policy? This is a schematic representation of the link between science and policy. You don't have the politicians, the officials, COBA. You have SAGE, who is the, I don't know whether I should spell these things out for everyone, but is the civil emergency group. Then we have the SPY groups, SPY B, which is the behavioral, and SPY M, which is the modeling, and basically, and later on we had lots of scientists joining this adventure. So how did this work? In particular, how did the group that we are being part of work, and how did it relate to the decision or of the political in the political scene? How did it inform and provide evidence for decision and policy? Okay, SPIMO stands for Scientific Influence Advisory Committee. It's a group that was constituted during the H1N1 pandemic in 2009. Supports SAGE, which is the Scientific Advisory Group for Emergency, in terms of quantitative analysis of data, particularly in trying to understand what the transmission dynamics in a pandemic setup is. Was maintained from 2009 to ensure the preparedness in the event of a new pandemic, and they recently has been extended to deal with all emerging diseases, not just influenza. And the members of this group come from a number of research institutions. So the actual process, how does the actual process work? So there are commissions, regular commissions that have been in the last 4 months from cabinet office. They will be expressed in terms of questions. They can be addressed by modeling, and I'll come to explain what this means. The swift answers were required, within 24 or 48 hours, from a group of a number of or a number of models. This is what the public has been sort of listening to, number of models. Then different results are presented. We've been discussing within the group. A consensus is achieved. The consensus is communicating again back to SAGE. There is a SAGE discussion, and then the translation into advice. So evidence translating into advice. So what kind of questions were being asked or have been asked over the last 4 months? Of course, they depended on the phase of the pandemic. There was a containment phase where there was an attempt to contain the pandemic through tracing and testing. So to try to understand how many resources, what kind of level of resources would needed, questions were asked of the type, how many people will get infected, when is the peak going to be likely to be occurring, what is the likely duration of such a pandemic, and what groups and geographical location will be worst affected. There was then a mitigation phase where there was an attempt to, we've learned this flatten the curve or other expression of similar type. In that phase, questions of the type, what non-pharmaceutical interventions are going to be most effective for this? The isolation with symptomatic individuals, close schools, perhaps ban big gatherings. And then in the suppression phase, the question were, how is the pandemic progressing after the lockdown? When is it going to be safe to reinstate social networks? So these were political questions which were expressed in terms of modeling. Now, what do we mean with this? I'll do a little digression if you allow me to do so. What models are we talking about? What models of what? So most of the models that we've been dealing with, or people have been putting forward or working on, are mechanistic models which do this. Approximate the unobserved infection process. Okay, so a pandemic or an epidemic starts when an individual who is infected enters a susceptible population. Then, of course, the pathogen is spread amongst the susceptible population. They all increasingly become infected, and then they recover, i.e. they recover from the disease, or they might die. So they don't take part into the continuous spread of the pathogen. Now, the rate at which the disease, the pathogen spreads depends on different key elements. One is the infectiousness of the individuals who are infected in the first place, and then the other component is the interaction between the infected individuals and the susceptible individuals. So we don't observe any of this, and we don't observe any of these other quantity I'm looking at now, I'm showing you now. So basically, in any point in time, in a population which is invaded by a pathogen, the population can be subdivided into susceptible, infected, or recovered. Again, we don't see them. But what we can do is to approximate this unobserved process through some models. What does this mean? We approximate them through a construct, which is a mathematical formulation, which approximates this phenomenon which we don't observe. And you might have heard, and I forgive me for some of these mathematical symbols, but you might have heard about SRI type compartment models. This is the simplest, which, as you can see, matches very closely the kind of a snapshot that we were looking at a minute ago. So any point in time t, we have ST, which is the group of people that are susceptible. We have IT, the group of people, the population that is infected, and the number of people that are recovered. So this is what the simplest of these models looks like. So what we are really interested in is understanding the rate of going from the susceptible to the infected box, which represents the rate at which infection occur. So now, so again, this is a construct, but the rate of infections need to be estimated, contains quantity which are unknown, because as I said earlier, the rate at which the new infection arise will depend on the infectiousness of the individuals, but also the contact between the susceptible individuals and the infected individuals. Now, in this setup, I would like to introduce the now famous R number, which is the average number, in particular the R0, is the average number of secondary infections caused by a typical primary infected individual in a totally susceptible population. Now you can intuitively understand that an epidemic or a pandemic is going to continue to expand and to spread if the rate at which the new infections are produced is higher than the rate at which people recover. And this is exactly the idea which is underlying the threshold of R bigger than 1. Intuitively, we do understand that if an infected individual produces less or more than one other infections, then the things could go, could explode or could die, at least in a sort of quite deterministic epidemic. But this is actually the underlying idea is the comparison between the rate at which infections, new infections occur, and the rates at which people recover. So having done this digression, let me explain what our role in SPI-M or SPI-MO has been, and what our work what the work that we've been carrying out. Now, we do have, or we deal with models of this type. In particular, there's been a model that we've been developing during and after the H1N1 pandemic, I should say, and has been published back in 2011, and then through funding from the NIHR, we've been able to develop this kind of modeling frameworks in a number of ways. So to account for heterogeneity, for instance, in spatial epidemics. So what does it look like? Again,
you've got about 1 minute, possibly maximum 2 minutes, okay? Oh dear. Did they include, okay. I paused when we were having trouble getting the slides up.
Okay, fine. So this is what it looks like. It looks like you can recognize at the top the structure of the SRI type model, for which we want to estimate the rate at which the new infections arise, and this is informed by data of different types. In the influenza, we had GP consultation, we had confirmation, we had different data. On the COVID, the data sources that we have were in principle confirmed cases, hospital admission, hospital bed occupancy, death, and serology. That is the clearest and neater signal, so we went for the deaths. Also, we have information about the serology, which gives us something about the antibody level in the population. So our model now looks like this. We do have a structural latent aspect of transmission that we don't observe, but then we use seroprevalence data, data on deaths and confirmed cases to estimate the rate at which the new infection occur. So this has been consistently used throughout the pandemic as data accumulated and used in different ways throughout the epidemic. What I'm going to skip some of the things, but the fullest application of this model has been through 7 NHS regions, 8 age groups, to produce a number of outputs, region-specific epidemic growth, effective reduction number of new infections over time, and then proportion population infected, short-term prediction of the number of deaths, and age-space probability of dying given the infection. These are some of the data that we used. We use that, so we say the serology, and then information on the interaction between susceptible and infected individuals. These are the typical plots that we could produce in terms of the new infections. These are the curves. The date is May, the beginning of June, mid-June. You can see there has been a spike in the early, in late March before the lockdown was introduced, and then it's gradually going down in terms of the new infection. As we acquire data, we learn more and more about the level of infection at the peak. We also produce.
Daniela,
Yeah.
is there one final point you want to make? Because
Yes, the final point I want to
one
make
point. Thank you.
is the monitor that we did, the ability to predict, and the consensus that the different groups have reached within SPIAM, and then now the level of infection is low, and our models need to be accompanied by also our new surveillance tools, which are much more local and monitor the epidemic at the local level, like in the case of the Leicester outbreak in the last few days. Great, exciting life and a professional experience. This is just the acknowledgement to the people that have been working with me. I'm sorry I could have done this more quickly. Okay, maybe there'll be questions.
Yeah, I'm sure there will. Daniela, thank you very much indeed. That was fascinating. I'm sorry that we had to tail it and rush through, but maybe we can share some of that data after the meeting, which I'm sure we will pick up on. So thank you very much for that. Excellent. I'm going to move swiftly on, if I may, to Professor Oliver Johnson, who's going to talk about population density and the spread of COVID-19. Oliver, over to you.
Okay, sure. So I'm just hopefully sharing my screen. So just be a second, hopefully. So while I do that, I'll introduce myself. My name's Oliver Johnson. I'm a professor in the School of Maths in Bristol. And this is a somewhat less technical talk, I think, than the previous one. It's a somewhat less involved analysis, but we were trying to pick out some of the features of the epidemic and how it spread and why it spread. So, is my screen visible, by the way?
Yes.
Yes, it is.
Okay. I'm not scrolling down at the moment. That's my problem. Okay, right. So it's an obvious question: is how do we compare the coronavirus outcome between different countries? I mean, I think there's a huge appetite for this. I think if you go back even early in March, certain newspapers started producing their daily graphs, and they were being shared on social media. And my sense has been that that's been premature at that stage, that if you're going to compare countries, you have to do it very carefully. You almost certainly shouldn't be doing it yet. There are various reasons for this. So one of which is that different countries collect data in different ways. They collect it at different speeds, they have different standards. And so I think we should be resisting the temptation to make comparisons. But if you must make comparisons, I think you have to do the right comparisons. So, for example, a sort of simple calculation is that per capita infection is the only way to really think about things. I mean, a sort of simple calculation here is if you think about a country like Ireland. Ireland has about 5 million people. We know from the work of people like Daniela and the MRC that the fatality rate is probably about 1%. And so if you multiply those two numbers together, you'll see that what you end up with, if everybody in Ireland was infected, which could almost certainly not happen, you would end up with about 50,000 deaths. So immediately you can see that Ireland could never have as many deaths as the USA has had. It's not right to compare those two countries on the basis of raw numbers. But there are other things as well. I mean, what we know is not all patients are alike. We know from work of people like the MRC that factors like age, obesity, diabetes, they're all very significant in terms of determining the risk. And so if you think about a country, how you might expect them to perform, if you know the percentage of the people that have those particular factors, then that's going to have a big impact on death rates. So I think it's fair to say that not all countries are on the same playing field. Not all countries are facing this epidemic in the same position. So beyond that, an obvious question is, well, what else might make a difference? We've talked about some of these sort of underlying things, but what else is important? And it kind of seems obvious that population density should matter. I mean, what we know is that COVID-19, it seems to be a disease that hits cities first of all. I mean, if you remember the horrible scenes in New York City, the disease seemed to be spreading very, very fast there. And that's very intuitive. I mean, the more people that you have packed into an area, the harder it is to socially distance. There should just be more contacts in day-to-day life. And so it feels like the virus should just be spreading faster. And this is something we can test. I mean, what we can do is we can say, okay, let's look at European countries. Let's compare European countries. We're very fortunate in this epidemic that we have almost live data from nearly every country is being collected and is also being disseminated on the web. So we can do this. We can look up data for population density of different countries, and we can measure the rate of spread. So what we could say is something like 5 days after a particular country reached 5 deaths, how many deaths does it have? So what we might imagine is that the bigger the population density, the faster the spread. And so what we can do is we can pull up our favorite graphing package and we can test this. And what we end up with is a picture that looks something like this. So what you see is I'm plotting the population density across the bottom, the number of people per square kilometre in that country, and I'm plotting the number of deaths 5 days after the 5th death up the left-hand axis. And what you can see is what statisticians would probably technically refer to as a mess. I mean, I've drawn kind of tentatively a line that's going up, but the kind of key number here is this little p. The little p says 0.13. What that basically means is that there isn't a trend here that's statistically significant. So although we believe population density should matter, based on comparing European countries, it doesn't particularly seem to. Which is a little bit surprising, but what we can do is we can look at a country like Spain. If you look at Spain, they're the second highest for deaths in this sense. You can see Belgium right up at the top, you can see Spain further over. But what you notice is that Spain doesn't appear to have a particularly high population density. Now, that's of course true, but equally, what that suggests is that we're not measuring population density in the right way. If you think about a country like Spain, Spain has a huge area in the center of the country which is practically empty, and it has some very densely packed cities. Barcelona is packed in on the coast. There are millions of people living very, very close together in Barcelona. And so somehow we shouldn't care about the center of the country. We should care about the cities where it's spreading. And you see a similar picture if you look at US states. Actually, for US states, there is a better trend. The p-value is better. This is more convincing. But still, if you look up at New York had, as I've said, a very fast rate of spread, but not a particularly high population density. And the reason for that is something to do with the geography of New York. Upstate New York is very empty. Manhattan is what you think of, and there are a lot of people packed in there. But beyond Manhattan, there's a lot of area where not so many people live, and so that's affecting the overall density. And so if you think about it a little bit, the population density kind of isn't doing the right thing. That what the standard population density is saying something like, if we pick a random point in, for example, New York State, how many people live near it? Now, it's quite likely that that will be a random point in space that's somewhere upstate. It'll be somewhere where there aren't very many people, because although Manhattan is dense, it's very small. But of course, the virus doesn't do that. The virus picks a random person. It doesn't pick a random point in space. You know, we could think that a random person will fly in with an infection and the virus will spread from that. So the question we should be asking is, if we pick a random person, how many people live near them? Now, it's not obvious that these aren't the same question. It's sort of slightly subtle to think about, but it turns out that they aren't the same question and the answers are different. So just to illustrate this, here's a kind of toy picture. That what we have is I'm kind of visualizing here, we have 100,000 people in a 10 kilometer by 10 kilometer region. And what I've done is I've spread them differently. On the far left, we have people spread evenly within this region. On the far right, I have everybody packed into one city, and in the middle, we have something in between. And so the sense is that the standard population density will be the same. We've got the same number of people in the same total area. But if you think about the virus, if you think about the sort of lived experience, we know that the virus should be spreading faster in the right-hand scenario than the left-hand scenario. In the right-hand scenario, there are just more people who will be closer to other people. So it turns out that this is something that people have studied. I mean, we're lucky. I said we had access to COVID data. We also have access to population data. We're lucky to have had access to something called the World Pop database in Southampton, which gives us the population on a 1 kilometre square grid. So we have very, very precise gridded population density data. And this is absolutely fascinating. You can spend hours going into this, looking for high density squares in particular regions and, you know, seeing which bits of which cities are the densest. But anyway, based on this, what we can do is we can look at two particular measures of this so-called lived density. So the lived density, there's one measure which was introduced by Alistair Ray. There's another measure that we call the quadratic, or the population weighted density, that was introduced by Craig. And to me, these measures are more intuitive. And I'm not going to get into formulas and equations, but what I can show you is that if I go back to this sort of toy example I had at the beginning, the standard density in each of these cases is the same. The standard density in each of these cases is 1,000. But what we see is if we look at these non-standard densities, then in the first case, it's still 1,000. In the second case, it's 10,000. In the third case, it's 100,000. So these non-standard densities pick out the fluctuations, the sort of lack of uniformity in the way that the population is spread out, in a way that the standard density doesn't. So it seems like these are good measures. And what we can do is we can repeat the plot that we did before. Oh, sorry. In fact, before I do that, I'll just show you some values very quickly. I mean, for me, the most interesting value of all is Germany. I mean, there's been so much discussion of the UK versus Germany. And if you look down the right-hand column, then measured according to this weighted density, Germany has an astonishingly low measure. Germany has a lower density by this measure than countries like Sweden and Ireland that we tend to think of as not being particularly crowded. So what this is saying is that the sort of lived experience for somebody in Germany is not to be as close to as many people. And so this may, to a large extent, explain why the virus hasn't spread as fast in Germany as we might naively think. And we can see this on the plot. So if we first of all look at this lived measure of Ray, that what we're seeing is, again, we're seeing a small p-value, but we're seeing that we're picking out now 26% of the variation. So 26% of the variability between countries is explained by this non-empty measure of Ray. But the population weighted measure does even better. If we look at this, what we're seeing is that 49% of the variability between countries, between European countries, is explained by this one single number, by this one single non-standard population density measure. And if I had longer, I'd leave it up here so that you could pick out your favorite country. But if you look here, we see the United Kingdom. The United Kingdom is ever so slightly above the line. Germany is ever slightly below the line. But essentially, Britain and Germany have both had the kind of outcome that you would expect given the value of this population weighted density. And so if you want to talk about the real success stories would be somewhere like Greece, where Greece has an astonishingly high density, but actually has managed to keep the number of cases down. So this is an interesting measure because it allows us to start making slightly more considered judgments like this. And obviously I focus just here on the initial rate of spread. I've said, okay, so 5 days after the fifth death, this predicts this well. But what it turns out is that actually it predicts the sort of trajectory of the pandemic much longer as well. What I've got now is I've got a similar plot, and all I've done is I've shaded the points in according to this sort of per capita measure. And so what you see is that the countries in red are the countries which have had a lot of deaths in total per head of population. And it's countries like Belgium, Spain, France, UK, Italy, up in the top right quadrant of this graph. It's the countries where the population weighted density is high, this quadratic density is high, are the countries that have been hard hit. And so, as I said at the beginning, we can't just naively think all countries are the same, they're on a level playing field. So that's really my conclusion, that firstly, these non-standard measures of density can explain to a certain extent the spread of COVID, and they should really be taken into account when we start making comparisons, when we start comparing countries, when we have all the data. We're going to have to think very carefully about factors like this. Now, I've slightly shoved things under the carpet here. I haven't told you the whole story because I've only shown you comparisons within continents. And of course, if you think about somewhere like Hong Kong, Hong Kong has an astonishingly high density, but not many cases. So I'm not saying that this is a sort of universal rule that works across all countries, but certainly at the level of European countries, it seems to be saying something that's quite interesting and quite surprising, and that the non-standard measures are picking out something that the standard measures have missed. Okay, I'm conscious of the time there, so I'm going to stop. I'm going to say thank you for listening. And I'm just going to point you at the preprint. This is a sort of version of the preprint. We're hoping to have a revised version of this up reasonably soon, but the preprint is up on the archive website if you're interested in looking more into this. So thank you very much for listening.
Thank you, Oliver. That was absolutely fascinating. Literally, as you started talking, the BBC posted that the UK was, making international comparisons, produced a chart and said that the UK has been hardest hit in Europe by COVID. So you're absolutely right. These comparisons are being made all the time, and it's very interesting to have such an insight into understanding those. And I hope that what we can do is potentially circulate after this the link to that and the other presentations, assuming they're in the public domain, so that people can go through them again and read a little more. But Oliver, thank you very much indeed. Absolutely fascinating. On to our final presentation, which is from Professor Joe Martin, who's going to talk about data and information, pathology as a model system. Joe, over to you. You're muted, Joe.
That's all right. I'm going to start screen sharing. And go here. Excellent. I hope that's come up there for you. And I'm Joe Martin. I'm Professor of Pathology at Queen Mary University of London, and I'm President of the Royal College of Pathologists. I'm going to quickly go through why what I'm going to say matters to you, talk about big data, big secrets, and the big future. So we've been talking about COVID. We've been talking about a lot about COVID, and particularly about COVID testing. You'll also be aware that we've heard a lot in the press about testing numbers, and there's been a lot of discussion about the particular numbers, whether we've got the right numbers, whether we're going to capacity. Testing isn't something that you just count, honestly. It's designed for a purpose, it's for patients, it's for those who care for them, and as we've been hearing very eloquently this evening from Professors Richardson, DeAngelis and Johnson, data collection is for a population level also. It's a very conscious use of skilled professionals and materials, and it needs to be done in a pathway and for a purpose. It's not just COVID. So currently you have a 1 in 1,700 risk across the UK of bumping into somebody with COVID. Obviously that will differ depending on your lived population, but of the population more broadly, pathology serves you from before you're born through to after you die. So we've got 17 different disciplines, ranging from reproductive sciences with the assisted conception, so that's the before you die bit, through to post-mortem pathologists, histopathologists such as myself, who will study disease after death. We serve the population across biochemistry, hematology, transfusion. When you're a teenager and you catch all sorts of different disorders from your colleagues, we will help diagnose. So we do the microbiology, the virology, the immunology. And so we're very much at the heart of this particular pandemic. Why should it matter to you individually? 50% of those listening will have had or will develop cancer at some stage. Anyone born after 1963 will have had a drop of blood taken and will have had newborn screening. 96.7% of the population has newborn screening currently, and that looks at a range of different disorders. And all that requires data and data linkages, and it requires statistical analysis behind the scenes to compare the various programs, the various population level data, but also the local data. The big data comes in very big data. So across the UK, we have about 15 tests per person. That's 67 million of you. 630 million tests a year go through our blood sciences labs. Huge, huge, huge numbers. One trust alone, so Barts Health Trust is the trust in which I do my clinical work. They handle 26 million tests a year. Nationally, £1 billion plus, and it costs £2.2 billion pounds a year. So huge amounts of data going through our pathology systems. And all this is capturable and transferable currently. It's been transferable currently because there's been, during the epidemic, an investment by NHS Digital in linking up laboratories. Now 100% of laboratories are now linked for COVID testing, the COVID testing results, both serology and virus, using the National Pathology Exchange System, which is essentially middleware that can help transmit data without double entry through systems. And they're also connected up to the Public Health England system. So when you're looking at serology data from the NHS, you'll be looking at our data, which has come from our labs through that system. We link into primary care systems, and this is some of our data architecture. This is just Barts Health data architecture, and it looks like something that you probably don't want to go near at all, and I can understand that entirely. So the data that you're getting, the data that gets transmitted to GP systems, the data that gets transmitted across the system is supported by an absolute spaghetti junction of middleware, products that help. See, I don't know whether you can see my arrow. Can you see my arrow here? So there's a cyber lab system in the middle that can allow patients to see data. They link through to the sexual health services. They link through to the blood tracking systems at the bottom for transfusion. We have clinicist data, which is where I will report electronically onto the system. I'll put my reports on and I will code them. And then we can look for the codes later. Those codes will also be transmitted through to PHE for the cancer registries. And the COVID data follows this as well. So this is data architecture underpinning some of the data that you'll see used in a day-to-day basis here. The data that we produce also goes to a range of purposes that you may not be aware of. The data that we produce is not just those lab tests, but it's also genetic data. And increasingly, the amount of detail that you can get from a genetic read, particularly with whole genome sequencing, is getting enormous. And we do that both for diagnostic purposes, but we also do it for research purposes. And that data is huge. So this is the National Cancer Institute Cancer Genome Atlas, where they're looking at essentially different genetic reads from different tumours, and you'll see the volumes. So 2.5 petabytes of data, the equivalent of, you know, thousands, hundreds of thousands of DVDs. And that data is useless as it is, but it all feeds into information. And that feeds into information not only for clinical diagnostics, but also for research diagnostics. One thing about pathology is we don't just serve humans. So our college also has veterinary pathologists as part of it. And so every discipline I've talked about has its corollary in our veterinary pathology community. And the veterinary pathology community also looks particularly closely with us at antimicrobial resistance as we look at surveillance data for resistant organisms and for unusual organisms. This is Nelson, our golden doodle, and he's a mutant. He is demonstrating his mutation. Domestic animals, domestic dogs, produced a mutation early on in evolution compared with wolves that raises their eyebrows, which makes them look more appealing, and therefore they're more likely to be fed by humans. So Nelson is demonstrating his use of that evolved and maintained mutation. We also use the data in every day. So all your laboratory services, if you go through a health service laboratory, if you have any testing done in a health service laboratory, we have accredited systems, and the data that we produce on a regular basis is fed into surveillance data, quality standards, proficiency, performance. So we use a lot of our data on an ongoing basis. So we look at variation between batches, we run standards through what we do, and we compare performance on particular analyzers. We know that there can be a difference in the output of different analyzers in the same hospital, and we can track that, and we can track any variations in that, and we use that data to monitor that we're doing a good job. So when you're talking about quality control, and we've heard a lot about that in relation to some of the non-NHS labs recently, we are talking about this sort of system behind your testing. We also use it in molecular analysis, and the sort of data that we produce can tell us whether we've got a contaminated sample. Some of the comparison of the genetics can tell us whether we've got it from the right patient. Could it have been mixed up? Is the base calling consistent and reliable? And some of the data that we use is reported in comparison to standard databases. And that comparison is really important. Particularly in genetics, we know that some of those databases that we use for comparison are biased. And they're biased towards a white population. So our genetic databases globally, not just in the UK, are skewed towards a white Anglo-Saxon heritage with fewer Black and minority ethnic contributors to those databases. And we know now that that can cause problems. So we know that some people have been told that they have a disease, where actually it's a normal variant for their genetic background. So we use our comparison with existing data for that. And where that data is not adequate, as it is currently, we try and improve it. Big future, more use.
2 minutes, if that's okay.
Certainly, we're virtually there. Big data feeding into more developments. So there's a MinION, that little thing that looks like a handheld scanner, is a handheld DNA sequencer. We can start to look at protein sequences, and we can start to elaborate the data that we're seeing in more user-friendly ways. We can start to use some of this for AI and decision trees also. We can start to look at it at a population level to look at variation in practice and where people perhaps aren't getting access to the testing they need. And we can correlate it sometimes with the mortality that overlaps that. This slide is to remind you that we're doing this all on some systems which are 30 years old and not fit for purpose, but we do it. We have add-on systems that we know are not going to end well. They're not ideal, and perhaps they were a silly idea, but they've been cobbled together because we've been short of cash. But the investment hopefully will go in that will end up with us being able to much more easily and readily manipulate and demonstrate the data flows nationally that we have a real wealth in, and that's very much underappreciated. It's not just a test, it's biological data, it's population level data, and it's a huge resource for our country. I'm going to leave you with that. I think probably everybody's a bit tired at the moment. Thank you.
Jo, excellent. Thank you very much indeed for that. I'm staggered by some of the numbers that you quoted there. It's an extraordinary amount of data, and I'm sure this is a discussion that we can potentially have about how we could support submissions for more investment in handling that data. Right, so we've had 4 excellent presentations. We're now going to go to questions, and I think my colleague Carol Moynihan has a question, and someone is now going to unmute Carol so that she can put her question to whomever she wishes. Carol, can you indicate whether it's a sort of general question or a question to a specific panellist?
Okay, thanks very much, Stephen, and thanks for all the presentations. They were really interesting. I have my mutant currently lying at my feet, desperate to go for a walk, so I'd better be quick. Professor Johnson, can I maybe just make a point, and maybe you can make a quick comment about it. Now, I want to make a point in defence of Belgium, because I understand that Belgium's figures were so high because they've included absolutely all deaths, care homes, hospitals, even suspected COVID deaths, which we haven't done here in the UK. So it's not necessarily as bad as, or maybe we're all worse than we're shown in that. Maybe you can come back on that. But could I maybe just ask a general question, and it's to everyone? I mean, that's been really interesting presentations, but how well do you feel your data, your research on data has been taken on board by government? Because some of the decisions that we've seen taken over the last couple of months seem to be taken at a whim or on the hoof. So is the government reacting proactively to this crisis, or is it more of a panic reaction to what's going on?
So who would like to comment on that? No one will be offended. We're all used to hearing harsh truths.
Well, I can answer the question about Belgium, which is, I think you're entirely right. So, and I think this was pointing to what I was saying earlier about that different countries collect data to different standards. I mean, hopefully by only looking at the spread, you know, from 5 deaths to 5 days later, if we're collecting a factor too many, it should be consistent. But yes, it's a good point.
Thanks. Professor Johnson, can I also, I don't know if you're making your slides available afterwards, because I found those, the graphs absolutely fascinating. So if they were, I would love a copy.
I believe they're all going to be accessible, yes.
Okay, thank you.
Thank you. And anyone care to comment about how the government has used the information that you have potentially supplied into them? Daniela.
Well, that was my attempt. Sorry, it was too much material. But there's been serious work in the last months to provide the government with evidence of ongoing transmission, evidence of all sorts of evidence. And so the decisions have not been made as a reaction. It's been the work of big groups from politicians to scientists of different types, more or less methodological or quantitative, behavioral scientists. There's been an awful lot of input into the provision of evidence to the government. So I
suppose my question is more, I understand that all that expertise has been available to the government, but sometimes the decisions don't seem to reflect that level of expertise.
Well, there are lots of different, I suppose that there are lots of different components to decisions of that type. It can be just one type of evidence. It's a combination of considerations. So I think all the people like me that have been working to provide evidence have done a very good job.
Thank you.
Thank you very much. Right, our next question is from Professor Ian Haynes. So I think, Ian, someone will unmute you and then please fire away. Ian, are you still with us? See if I can find Ian.
Wait a minute. Is that all right?
Yeah, that's perfect.
Oh, good. I think my question is for Oliver. In the Public Health England report on understanding the impact of COVID-19 on BMA groups, there's a note about housing producing a potential risk, and particularly because those groups tend to live in housing where there are more people in the household than there are rooms, and there's a significant number more in that category in BME groups than there are in the rest of the population. And now I was just wondering whether there was any data, and this is going down below your square kilometre. I wondered if there's any data about the problems of high-rise housing, thinking about the fact that people have to use lifts all the time, that people are packed into those sort of places much more, often narrow staircases, whether there's any research or any information about how that increases the risk of spread of the virus. And just to take it one stage further, whether that could be an issue for high-rise hospitals.
It's a good question. When I first started talking about this, I started talking about density, and people said, oh, what you should be thinking about is overcrowding. And to me, that felt like the same thing, but you're absolutely right that it's not, that it could be multiple people in a room is more of a problem. I mean, from a statistical viewpoint, it's sometimes hard to separate these things because you may have a lot of these different measures that are all quite strongly correlated with each other. So it may well be that in places where the density is high, then the overcrowding is high, for example. So how you then start to separate out these effects, it becomes a difficult problem. So I'm certainly not claiming that this is the only measure. I suspect there would be other measures that would give you equally good or possibly even better correlation, but it's quite striking that the density does seem to do a good job in this sense, or these non-standard densities at least do a good job in this sense.
No, it wasn't a criticism of what you've done, which I found absolutely fascinating. It was just I was thinking about the issue of that kind of housing potentially being a significant factor.
And I just add that I think from basic principles, you know, the way the building and the way people are, it's designed to circulate and interact is certainly, you know, from basic principle that we know about how transmission occurs, could certainly be a factor. And for example, they have found that it's not necessarily, you know, it's where people share space like cafeterias, for example, in hospital or sort of communal brews, which viruses can be transmitted. So similarly, I think from just basic principles, if there are occasions where people are come in close contact just because the building is designed that way, this is, you know, this would be, you know, necessarily a factor for increased possibility of transmission. And this is why I think they're trying to think of circulation around the buildings, one-way circulation or something, to avoid these places where people actually, you know, get into very close contact, like bottlenecks.
Thank you very much indeed. Thank you for your question, Ian. We're now going to go on to Dr. Anthony Kearns. Anthony, are you there? Or someone will unmute you. Anthony, are you there? No. I think Anthony may have left us by the look of it.
Yeah.
Oh, there we go. He's there.
On this.
Oh no, here we go. Anthony, over to you.
Hello, I'm here.
Yes.
Can you hear me?
Question away, yes.
All right. Can I just read my? I'll just read my question out. Stop that computer. Are you ready? I'm just going to read my question out.
Lovely.
Yep. The question, with respect to rate of spread of COVID-19 and the apparent high death rates in the UK, should not the UK statistics be modified, brackets be lowered, to reflect those, for example, who are in palliative care and would have only a short life expectancy, for example, and are far more vulnerable to the spread of the disease?
Anthony, thank you. Would anyone care to comment on that? I suppose it's the question of excess deaths and
Yes.
over a period of time. Joe.
So my suggestion would be no. That all causes of death should be equally represented. I think if we can segment data almost secondarily, I think that may be helpful. I think we're missing some causes of death that may be indirect causes of COVID, because the post-mortem rate has decreased. And we have some data from Oxford, some data from other colleagues suggesting that there may be some potentially non-fatal conditions which have ended up being fatal because people have been reluctant to go to hospital. So I think it's quite important that we record COVID figures, and particularly COVID figures, and also the corollary where deaths are not related to COVID at the moment. So we don't want excess deaths, non-COVID deaths, to go up as well. So
no, okay. Thank you for that. I don't know if anyone else wanted to make any comment. No, in which case, thank you. If everyone's happy, I know we're running slightly over time, but if everyone's happy just to carry on for another few minutes just to cover the questions, because we started a little late. Is that okay with my panelists? Yeah, thank you. The next question, I've got 3 more questions, but the next one is from Dr. Paula Doman. Paula, can we find Paula?
Yes.
We're very faint, I don't know.
Can you hear me better now? No?
No.
I'll probably shout my question, hopefully it gets through. So my question is for Professor De Angelis, and that is, how are models validated in the course of the ongoing outbreak, taking into account uncertainty associated with the level of data collection when there was minimal initial population testing?
Thank you. Now,
I think you have to repeat it. Can you?
Okay. I've got it here in front of me. So, so the question from Paula is, how were models validated in the course of an ongoing outbreak, and thus how did they take into account the uncertainties associated with the level of data collection, bearing in mind that there was minimal initial population testing? So I think it's really, how did you validate the models when you hadn't got very much data to start with?
Well, it was very difficult at the beginning. In fact, if I had organized myself a little bit better, I could have told you that the models that I tried to kind of summarize with the example I gave were used in different ways at different stages of the pandemic. At the beginning, they were used to simulate what would have happened. And as soon as the new little data was starting to become available, they were used to estimate the status quo, what we call the nowcasting. Okay, but the uncertainties in this pandemic are still there. They've been there at the very beginning, and it's very difficult to understand how well a model is doing. I've kind of hinted in my presentation that perhaps one of the ways was to try to understand how well the models were predicting what they were supposed to be predicting. But eventually, there is really a lot of uncertainty, and this is why there is a consensus being made from the government to put together different models and different approaches, because there is so much uncertainty in any single one that perhaps only an aggregation, a combination of results can give some more robust estimation or quantification of the problem. But you're absolutely right. There's been an escalation of data over time, and an escalation availability of data which again were not really terribly clean, and that's why we use the DETs, because the DETs were a little bit neat signal. But you are right, it has been very difficult, and is still difficult, especially now that the number of infections are going down and the numbers are low. Anything that we saw before has got much less informative.
Thank you very much.
Forever, but obviously we had to stop.
Thank you. No problem. Right. Another question, which is from Dr. John Doodney. John?
Yeah, can you hear me there, Michael?
Yeah. Oops.
Okay, I'll read my question out. It now appears that most people who are infected with coronavirus remain asymptomatic. A recent study published in the BMJ from research on a captive audience aboard a polar cruise ship suggests that this could be as high as 80% of those infected. Is this high level specific to coronavirus, or do other viruses such as flu and the common cold also have such high rates of asymptomatic infection? And if it is specific to the coronavirus, should we be looking at mass testing of everybody in a locality experiencing an outbreak to ensure that track and trace is effective? And I'm thinking particularly about Leicester at the moment.
Thank you, John. Anyone?
Happy to. I don't think we know enough about asymptomatic, a lot of the asymptomatic viral transmission, because we don't test people who are not symptomatic broadly. I mean, there've been some research trials on some research studies, but generally we can find those diagnostic tests to clinical settings. It's interesting. The NHS is actually ramping up for winter as well, because we know that coming into September we'll have flu circulating as well as COVID, so we'll have to change our testing strategy to include testing for flu as well as COVID, particularly in A&Es and in vulnerable groups.
Great, thank you, Jo. And then,
can I add something?
Oh yes, Sylvia.
Yes, what I wanted to say, the fact that asymptomatic can transmit is a particular characteristic of this virus, which makes it particularly a threat. You know, this was, when this was starting to be known, everybody shivered, because it's clearly much harder to contain. The idea of blanket testing at a local level is certainly an idea which should be explored when we are in a sort of suppression phases, and that there are local or very localized outbreaks. And if that technology can be made possible in the future, it would certainly be, it's a strategy which has been used by a country in the Far East, for example, with some effectiveness also in New Zealand and so on. Of course, it depends very much on being able to ramp up capacity. So it's part of a surveillance system. It needs to be integrated.
Thank you. Right, and then I've got the last of our pre-submitted questions, which is from Lisa Riviera.
Hi.
Lisa.
This question's for Professor Johnson. I was just wondering how he would factor in and assess the government's effectiveness when taking into account, a country's governmental infrastructure. So, for example, would he support developed nations and states in America each deciding on their own policy measures to implement, and how does that affect the stats?
It's a good question. It's maybe too much of a political question for me. I may leave that to the political experts. I mean, we could separate off in this data, for example, the developed countries within the UK. We chose not to for whatever reason, but we could analyse them in the same way. It's an interesting question in terms of the US states, because obviously they have both local and national things going on, and so it's made hard to separate out those two things within what we see. Does that answer the question?
Lisa? Okay. In which case, thank you for that. I've now got, I'm going to go and see how time goes. I'm going to go ask Dr. Trevor Crichton, I think, has a question from the floor. Trevor, are you there? You may be the last one. It depends how quick we can be.
Can you hear me?
Yes.
Right, okay. Professor Johnson, you gave a splendid and extremely interesting talk. Thank you. I've got a general question. In the UK, it's been consistent that about 1 in 7 or 1 in 8 people who contract COVID will die. Why is this so consistent despite the apparent changes in the data collection methods being used to identify cases? And this figure of 1 in 7 or 1 in 8 has been consistent since March.
Okay, thank you, Trevor.
Well, I mean, you started asking me, so I will say I'm not sure it is 1 in 7 of infections. It's 1 in 7 of cases. So it's 1 in 7 of people who test positive. So obviously 1 in 7 of anybody being infected, it would be an alarming figure. As to whether that's changed, I'm not sure. That's my.
Okay, you've gone mute, Oliver. Don't know if that's deliberate.
Slightly. I mean, there are all kinds of complicated effects going on here. I mean, for example, there was I think it was the Centre for Evidence-Based Medicine in Oxford were saying that it seemed like the proportion of deaths to people in hospitals were dropping, but you have to be careful with that because essentially the recovery time is much longer than the time to death, so the kind of population isn't being weighted properly in those two comparisons. So there's all kinds of things that you have to be careful to unpick when you're thinking about these things, certainly.
Okay, thank you very much. And
also has to be said that you need to be careful not to pick up the wrong population to look at these statistics, because different population might be biased. So it's very difficult to estimate the mortality rate.
thank you very much indeed. I think I'm going to draw things to a close because I'm sure we could go on like this indefinitely, because it has been an absolutely fascinating discussion. I think the presentations were varied and very insightful, gave us different perspectives on some of the challenges that tackling this pandemic presents. And I hope that if we are to see future pandemics and potentially a second spike, what we have learnt as part of the first wave will stand us in good stead for any future waves. So on that, I'm going to draw it to a close. Can I thank all our speakers, to Sylvia, to Daniela, to Oliver and to Joe for their excellent presentations, to our questioners, and of course to the team at the Parliamentary and Scientific Committee, which is Lee Jeffs, Karen Smith and Ben Allen for organising this, and to Charlotte Hall, who we haven't heard from at all this evening, but is capturing everything that's being said and done, and will write that up as a report which will appear in the Science in Parliament magazine, which gets published over the summer. So other than that, thank you all very much indeed. We will be meeting again in September. Whether it will be virtually or in person, I don't know yet, but we will be looking at non-tumour cancers. So until then, thank you all very much for your attendance, and I hope you've enjoyed this evening as much as I have. See you all again soon. Thank you.
Thank you very much for having us.
Thank you.
Thank you.
Bye-bye.
Thanks.
Bye all.
Thank you.
Bye.